Okay, hi everyone, my name is Dana Bakula and I'm a pediatric psychologist here at Children's Mercy and currently one of the KL2 scholars. So I'm going to be talking today about my KL2 project that's funded by Frontiers, which is the development and pilot testing of a mental health intervention for parents of children with pediatric feeding disorder. So I'm going to talk a little bit about my journey here to doing this very specific type of work, and then I'll touch on pediatric feeding disorder and its association with parent mental health conditions. I'll talk about the study aims of my KL2, which we are very close to wrapping up on recruitment for, so I have some preliminary outcomes that I can share and then talk about next steps. So obviously I'm talking about parent mental health in a pediatric setting, which is a very kind of specific area of work that is not super common to address in pediatric healthcare. So I wanted to talk a little bit about why I'm doing this work first. So when I started my PhD, I always knew when I was growing up I wanted to work with children, and I was very interested in psychology and mental health and well-being. And so I was very excited and interested to work with kids, learn how to be a pediatric psychologist, and help support children who had experiences of chronic medical conditions, which we know impact both their physical and psychosocial health. But what was interesting is as I got further into my training, both clinically and with research, I really started to see the impact that having a medical condition had on parents and the family system. So many of these parents are experiencing such high stress related to caring for their child's condition, worrying about the future and caring for their child, but also there are many other responsibilities, the financial impact, health insurance, caring for multiple other children in addition to their child with a medical condition. And so I really started to see that, yes, these chronic health conditions are impacting children, but they're also having a major impact on parents. And so I began to do research looking at, what is that impact on parents, but also when parents are experiencing more stress, anxiety, mental health concerns, what is the impact on children? Does that have a bidirectional relationship, and does that impact how their child is doing with a medical condition? I did a series of 2 different meta-analyses when I was in graduate school, looking specifically at parents of children with pediatric cancer. And we found through 40 plus studies that when parents experienced more anxiety, depression, post-traumatic stress, their children experienced more of these same types of problems, and their children had worse health-related quality of life. And so we're seeing that not only are parents experiencing more stress, more mental health concerns in this population, which is an appropriate reaction to their very challenging circumstances, those are having downstream effects on their children. And so as pediatric providers, it then becomes very important to think about how do we support those parents as a way to support children. So for my dissertation, I started to look much more specifically at what impacts parent well-being, parent stress, parent mental health when their children have medical conditions or acute medical crises. And so that led me, I finished my PhD, I started a fellowship at Children's Mercy and KU Medical Center combined that was a research and clinical fellowship in pediatric psychology, and I set out to figure out, okay, I've done research that really shows there is this relationship between parent mental health and child outcomes. We see that it's a problem, but what are we going to do about it? So during my fellowship, I submitted a KL2 award, which was fantastically supported by the Frontiers program, and I transitioned then into a faculty position about 1.5 years ago and started my KL2 doing work to develop and pilot a brief intervention for parent mental health, specifically with children with pediatric feeding disorder because they're such an at-risk population for these types of mental health concerns. So I just want to share a little bit about pediatric feeding disorder for those who aren't familiar. Pediatric feeding disorder is incredibly common in young children. So we know about 1 in 23 children under the age of 5 meet criteria for this condition. Children with medical complexity or developmental disabilities are much more likely to have pediatric feeding issues and have these types of concerns early on. And I want to be very clear when we talk about this condition, it is not simply picky eating, because most children have picky eating at one point or another during their lifetime, but it is really severely restricted variety or volume of intake that can lead to malnutrition, it can lead to nutritional deficiencies, it can lead to children actually needing G-tubes or enteral devices that put food into their body to help them survive and grow and develop. And we know that it has these biopsychosocial causes. When we look at this population, like I said, this is an at-risk population for parent stress and mental health. The literature to date shows that between 30 and 40% of parents and caregivers of these children experience clinically concerning stress and anxiety. So they would fall within a clinical range for their stress and anxiety, which is much higher than the rates in the general parent and adult population, although we know that parents in general are much more stressed than other adults without children. We published a study within the past year where we looked specifically at the pediatric feeding program at Children's Mercy. We had been asking for several years in our intake screening questionnaire about parent mental health and whether either of the parents has a significant or concerning mental health condition. And we found that 40% of the parents in our clinic, this is with a sample size of a little over 300, 40% of those parents were endorsing at least one of the parents in the household had a mental health condition. When we looked at more specifically what types of conditions, anxiety and depression were the most common, and many of the parents were also endorsing there was a postpartum onset. So we know that parents with children with medical concerns like feeding issues close to birth are at much higher risk for things like postpartum depression, anxiety. So nearly half of the parents that walk through our doors in Children's Mercy are experiencing these concerns when they come to feeding clinic. And the thing that really interests me in terms of how this impacts children with pediatric feeding disorder is that the treatment is biopsychosocial, right? So there are medical things that we can do. There are feeding therapists who work on the skills of chewing and swallowing, but there are also these behavioral skills that we teach parents to engage in around mealtimes to really treat and improve outcomes for feeding. But the treatment requires parents to engage in these positive mealtime interactions. It requires them not to put pressure or stress on their children related to eating, and that is incredibly difficult to do when you're experiencing significant stress, anxiety, depression, etc., especially when that's very tied up in how your child eats at meals, and meals can be particularly stressful for you as a parent. And so this is an adapted model of thinking about how anxiety can interact with parent-child interactions. But what we really see, both clinically and in literature, is that baseline parent stress and anxiety contributes to acute distress at the meal, causing the parent to be more likely to pressure their child to eat or engage in some of these behaviors we actually don't want to see. The child is more likely to become stressed or feel pressured, less likely to actually eat, and then that reinforces parent distress at the meal, which reinforces that parent stress and anxiety overall. So what are we doing about this? There was a consensus statement published in the literature in 2019 about pediatric feeding disorder, how it's diagnosed, what are the components involved, and under the psychosocial components, parent stress is listed as a contributor to pediatric feeding disorder. It is very clear in the literature that parent stress is very closely associated with pediatric feeding disorder, and it makes it very challenging to engage in behavioral strategies that support improvement in this condition. But the current standards of care in practice across the United States only involves on changing parent behavior, how they interact at the mealtime, but not their stress or anxiety or their coping that we know drives behavior. And there are no published interventions in the literature that have been used to address parent mental health in this population. So that is where my KL2 project has come in, is trying to adapt existing evidence-based intervention to address the needs of this population and try to figure out a solution to address this problem. And what we really need in an intervention for these families is something that's brief, because we as clinicians are already very overburdened in pediatrics trying to meet the needs of our patients. So we need something that is very brief, targeted. It's focused on the problem related to stress with meals, but also because parents are incredibly busy and overwhelmed, we need to be very targeted and brief and offer them workable solutions. It needs to be evidence-based. We need to use treatments that already exist that we can tailor to meet the needs of this population. And like I said, parents are incredibly busy and have a lot of competing demands. It needs to be very accessible to them. So we identified focused acceptance and commitment therapy, which is a specific type of psychotherapy or talk therapy that has a lot of research evidence behind it, as a really optimal model for this population. And one of the reasons it's so optimal is because this type of therapy, even when tested with 1 or 2 visits with a psychologist or a mental health counselor, has been proven to show meaningful clinical differences in stress and anxiety, because the goal is on teaching parents not to get rid of anxious or worried thoughts or stressful thoughts. It's to learn how to let those be and accept them for what they are, but then focus on what really matters the most to you. And we've seen in a small number of other small clinical trials that have used this type of treatment with parents of children with other medical conditions, that it can both improve parent outcomes, but also improve parent acquisition of behavioral skills if they're simultaneously learning behavioral treatments for their children. And the mechanism of action for this treatment is called psychological flexibility, which, like I said, is that ability to be present-oriented, accepting of your thoughts, accepting those as your lived experience rather than trying to change them, and learning how to tolerate those difficult thoughts in service of doing the things that matter the most to you. Some of our more traditional cognitive therapies will teach you which thoughts are adaptive, which thoughts are helpful, and how to build more realistic or helpful thoughts. When your child could die because of their condition, or when your child could become malnourished or be hospitalized because of their condition, those are realistic thoughts. And so this treatment also fits very nicely with the needs of this population of, I'm not going to try to change these thoughts that you have about your child's mortality or your child's illness. I'm going to teach you how to let those be and accept them as part of your experience. So our hypothesis is that psychological flexibility, that skill we're teaching, could change this dynamic and this interaction at mealtimes, where parents are better able to use those behavioral skills we've taught them, and it reinforces a new pattern of behavior. So during my fellowship, this is a case example that is currently under review, and we're hoping to be published soon, where we use this type of treatment approach with a parent of a child with pediatric feeding disorder. And we found significant improvements even in just the first 2 sessions of using this approach. I saw this family clinically, and so we continued to do 6 sessions until this parent kind of identified we'd met all of her goals and she was in a really good place. But I find it really significant that in just 2 sessions we made incredibly meaningful improvements in her stress, taking her down from what would be considered a high rate of stress down to a typical rate of stress for caregivers. So this brings me to my current KL2 study. Our first aim was to develop this intervention using focused acceptance commitment therapy for parents of children with pediatric feeding disorder using stakeholder input. So we had 2 different international consultants, one from Sweden and one from Australia, who are 2 of the only psychologists in the world that are doing this type of treatment with caregivers of children with medical conditions. And we also had 2 parents of children with pediatric feeding disorder serve as consultants to make sure we were really tailoring this intervention well to the population and designing it as optimally as possible. And then our second aim was to test the hypothesis that this intervention could result in some clinically meaningful changes. So we're looking at proof of concept. We're not looking at efficacy yet. We don't have that type of sample size, but do we have enough of an indicator that we should proceed with a larger scale study? And we're also looking at feasibility of this intervention delivery. And then my training plan, because this is a K award, involves clinical trial conduct, mixed methods research, ongoing content expertise, and grant writing, which has been incredibly helpful to career development. So I have just a little bit of preliminary data to share. That orange line is our recruitment rate. We were aiming, because this is a pilot study, to recruit 30 families. We're at 29 today. We've been at 29 for 2 weeks, so we just need to get one more, and then we'll be all done with recruitment. But we've had a really high rate of consent into the study. So first we screen parents for stress or anxiety, and we only enroll families who actively have stress or anxiety concerns. And almost all of our families are consenting when we say, this is the study we're doing. Would you like to be screened to see if you would meet criteria? 95% of them have said yes, which I think is a really nice data point to say parents are open and accepting of talking about their stress, of being screened for their stress and mental health concerns in pediatric settings. When we look at our rates, this is from the first 30 that we screened, because we haven't analyzed quite all of our data yet. We saw that very few people fell in the no stress range. So that blue for each category of stress and anxiety are those that are endorsing no clinically significant stress or anxiety, and then moderate to high respectively. This is some data from just our first few participants that we've analyzed so far, and for the most part, we are seeing that most parents are showing some improvement in stress and or anxiety. to look at proof of concept, which, like I said, is that kind of go, no go. Do we have enough evidence to proceed with a larger scale study to look at efficacy? We use something called a reliable change index, which is looking at the individual level, is the change large enough that it is not likely to be due to random error? And this is the analysis for anyone who's curious from the mathematics perspective. But so far, of those we've analyzed data for, 57% of the caregivers who've completed this 2-session intervention, which is very brief, very scalable, have had clinically meaningful improvements with that reliable change index on stress and or anxiety, which is very promising, and I think gives us good evidence to proceed to the next step of testing, assuming the rest of our data looks very similar. So the next step is that I've submitted a K23, which was, the revision was reviewed in November and received a score of 20. So still going back and forth with the National Institute of Mental Health, and have not received a notice of award yet, but we're very hopeful and optimistic that this could be funded. And the goal of this K23 would be an efficacy study of this intervention we have developed and pilot tested as part of my KL2. And we're not only looking at how this intervention impacts parent stress and anxiety, but we're also going to be video recording meal times between parents and their children and coding parent behavior at meals before they complete the intervention and after, to not only see are we intervening upon their stress and anxiety, but are we making meaningful changes in those interactions, those behaviors that we know are very important. We will also be doing some interviews with providers across the country to present this treatment modality to them and ask them about what would impact the likelihood for implementation, feasibility in their clinical settings, so that we can really, as we're testing this intervention, be also thinking about how would we implement this as the next step, and how could we make this feasible to make a standard of practice in the future. So with that, I just want to say a huge, tremendous thank you to my mentors on this project who've been mentors on this award, as well as my multiple case submissions that have hopefully led to the one that will stick, Ann Davis, Delwyn Catley, and Candace Fleming. I have an amazing research team, including multiple fantastic graduate students who serve as interventionists for this study, but also do tremendous work for our research, Allie Zaks, Taylor Harris, and Taylor Datillo, as well as Corey Sherman and Laura Slosky, who are incredible for our research team, the Frontiers program for funding this work, as well as many other individuals, too many to name, who've been so critical to the success. So I just want to end there and say thank you, and if I have time, be happy to answer some questions.
We do have time for a couple of questions. Raise your hand if you have one.
You mentioned that you had great success at recruiting parents to take part in the study. So who was doing the consenting? And do you have any tips on that for other people? Because this is a stressed group of people. You could imagine there'd be a fair chance that they would not want to do this because it's just one more stressor.
I think that's a fantastic question. For our current study, we have a very senior research coordinator who goes into clinic and is very adept at working with the providers and the nursing staff in clinic to figure out when do I have time to go in and talk to this parent without disrupting clinic flow. So I think that's been hugely successful. I will also say my dissertation study, when I was looking at parents, those parents were children newly admitted to the hospital, and I was told multiple times, you're never going to be able to consent these parents, they're going to be too stressed, overwhelmed, and our consent rate for my dissertation was like 96%, which was astronomical compared to what I expected. And I was the one consenting for that study, and my own personal experience was as soon as I mentioned that we wanted to know how parents were doing about their own stress, their well-being, so that we could help more parents in the future, parents would say yes before he even brought up compensation or what was involved. I think parents in our current society are so overstretched and unsupported, and then you add in that layer of caring for a child with a medical condition or medical complexity, and the lack of systemic support that we currently have to offer them. I think so many parents have been so receptive to this and so interested in research or work that meets their needs. I work with a parent who does a lot of advocacy related to parent well-being, and she is a parent of a child with a rare genetic condition. And she has said the number of times any medical provider has asked her about herself and how she's doing in the 8 years that her child has received very frequent medical care has been twice in 8 years that anyone has asked how she is doing. So I think these parents are very receptive because of how important this feels to them. Thank you. Yes.
First of all, I want to congratulate you on an impressive presentation.
Thank you.
With highlighting accessibility being such an issue for your parents and picturing that when there are two parents or perhaps more complicated set of parenting structure, have you been considering digital approaches perhaps for your intervention, or is that already part of the design?
It's a great question. When we, as part of the KL2, in working with our two parent consultants in particular, one of our questions was, should this be delivered via telehealth? Should it be offered in person? Should it be a hybrid? And they resoundingly said, this needs to be a telehealth intervention. We need to be able to do this from home virtually and have very flexible scheduling. Yeah.
Could I just add that there's increasing evidence for the effectiveness of standalone digital interventions where
Yeah.
a parent could plug in on a Saturday and the other parent
Yes.
on an evening during the work week, for instance. Just some thought for consideration.
Yeah, I think that's a great idea. And I think the types of things that we talk about in this intervention could definitely lend well to some of that asynchronous delivery would be a great future direction. Thank you.
Well, thank you, Dr. Bakula. She will be around today if there's any additional questions. I want to make sure we leave time to physically move. We're going into our first concurrent sessions.